Good morning, everyone, and we're just about to start our cardiac rounds this morning. It will be presented by our esteemed colleague, Dr. Jim Cherry. He will be presenting on cholesterol management, where we are now, and where might we be going as well. Good morning, everyone. Dr. Cherry, it's all yours.
So, thanks to everybody for showing up, and we're going to be talking about the evolution of cholesterol management since the 90s. And this is a picture we're starting with of somebody in the parking lot when I was at the Civic Hospital in the days before the statins were available. And it looks like Fred is going to go and pick up some cholestyramine, which is all we really had in those days, which didn't do very much. But he was a lot of fun in taking care of it. So if we go back and look at the early days of management, there wasn't a whole lot of data. And most of it, as we can see in the trial on the top right here, was from the 4S trial, which was looking at over 4,000 patients who had established coronary disease and high cholesterol. And we're looking at a starting point of an average LDL of about 3.5 to 4 at that time, and the benefit of treating with a statin in comparison to placebo. And there are other smaller trials that were done over time, some of which were not, even though large, were not well, didn't have a very high power because of poor effectiveness of some of the drugs in those days. So here's an example of one of the first major trials, and we have to look at it was extremely effective in comparison to no treatment at all in people who had established definite coronary disease with either a prior MI and not just risk factors, with a 30% reduction. But you can see, looking at the top left, that it took a year or two before the curves really started to separate that much to give the final effectiveness after 6 years. And here's from 10 years later. Now we started looking at comparisons of two types of therapy, and this was high dose atorvastatin in comparison to reasonably high dose pravastatin. And this had been set up to explore the relative effectiveness of the high dose versus the moderate dose. And it was felt, based on the initial data before the trial, that there really wouldn't be a big difference. And this was disproved, and likely cost the sponsor, who had pravastatin as their drug, a large amount of money. So, but it started to show us the benefit for high dose therapy. So we know that the drugs are effective, that is the statins, of course. And if we look at the efficacy, we can see that the starting doses give you most of the bang for your buck in terms of cholesterol reduction. And the earlier generation of pravastatin, simvastatin, had moderate efficacy of 30 to 40% reduction in LDL cholesterol at the higher doses available. And the second generation of atorvastatin and rosuvastatin had more like 50 to 60% reductions at their full doses. This, however, was not adequate. And if we look at, on average, the result of doubling the dose actually only reduced the cholesterol by an extra 6%. So the tendency of some of the family doctors in the early years, in the early 2000s, of increasing their simvastatin dose from 10 to 15 milligrams probably didn't have a huge effect on the total cholesterol reduction and risk reduction in these patients. So subsequent to those trials, we can see in this cartoon over a 10-year period, going from some of the earlier trials in early 2000s through ASCOT, which was more hypertension, and looking at addition of a statin onto hypertensive therapy and the efficacy in reduction in events, through PROVE-IT, which showed the efficacy of further reductions, TNT, which was treat to new targets, and this looked at low dose versus high dose atorvastatin, and all the cholesterol treatment trialist collaborations over the years. Later in such as 2011, there was the Jupiter trial and other trials looking at whether the drugs actually reduced events and reduced the cholesterol burden in the arteries, and was shown that this was effective, and that at high dose and reduction of the LDL substantially, there could be reduction in the actual wall thickness and cholesterol burden within the arteries once you got the LDL below 1.4. So the Canadian guidelines followed the evolution of these trials, aiming by 2012 for an LDL less than 2 or a 50% reduction. And the reason for this type of choice was the efficacy of the drugs, and being able to get a 50% reduction was considered a major benefit, even when you were starting from a very high level, because we couldn't get everybody down to below 2. The US guidelines changed a bit over the years as well, and there were optional choices, making it very difficult to understand the US, and at one point just putting them on a statin and not measuring the cholesterol for a couple of years was a guideline before they went back to having specific goals. The European guidelines on the bottom have been much more aggressive and targeted 1.8 for the LDL much earlier, and as we'll see later, they're even more aggressive now. So getting to goal, the benefit of treatment is obviously in the blue line, very much of a benefit in terms of event reduction with the statins. If we look at the event rate reduction versus the LDL, we can see as the LDL comes down, the event rate goes down substantially. The difference in the primary prevention is much less, however, even for the same numbers, because never having had an event, the event rate is going to be much slower, with a 5% incidence, even with an LDL of 5 in a 5-year period. These trials were done for primary prevention in quite different populations, and if we go back to the AFCAPS, which was the Air Force trial, that was done actually to try to decrease the number of fighter jets that were being driven into the ground by the 45-year-old pilots who had high cholesterol and were having heart attacks in the air. So quite a different population. The concern is, using the same diagram, however, is what happened when you started getting the LDL very low. And the concern for many years is that in the secondary prevention group, that there would be a flattening of the benefit and perhaps an increase in risk when you got the cholesterol too low, the so-called J curve, as I've circled there. So if we look at, in general, how do these people do? For a total reduction in LDL, they'll get about a 22% reduction in risk. The absolute reduction in LDL is what drives the results. We can see by the size of the boxes that a lot of the trials with large numbers only achieved an LDL reduction which was small, and therefore the benefit was in the 8 to 10% range in comparison to a lot of trials that were smaller, but did achieve an total LDL reduction of 1 millimole per liter, for example, going from 3.5 to 2.5, getting a 22% reduction. And the results in the 4S trial, having the 30% reduction over a 6-year period, would have been associated with about a 1.7 reduction in the total LDL. I had mentioned this is the effectiveness of high versus low dose, but there is still that significant residual risk that we have to look at in how we manage our patients and try to, despite these high doses of statins, further continue to help them to further reduce their residual risk. So many things contribute to this increased risk. There's modifiable and non-modifiable. So the easiest thing for us to do is to give some drugs to modify their lipids, modify their blood pressure, try to control their diabetes. Unfortunately, despite everything we do, a lot of the non-modifiable events such as smoking, lifestyle, physical inactivity, already having had an event, their weight, diabetes, inflammation, and metabolic syndrome secondary to all this, and also the relative risks of age, racial differences, and gender-related differences. We can't really modify that much. Even though we figure we can change smoking, not very many people unfortunately manage to do a good job on that. But at least we can try to give them the drugs for their cholesterol and their blood pressure and see if they take them. So if we look back at treatment, in the 1970s, there was niacin, and the bile acid sequestrants such as cholestyramine came in the 80s, but it didn't work too well. And then in the late 80s, there was a start of introduction of the statin drugs. And by the 90s, we had the second generation statin drugs by the later 90s, and addition of ezetimibe, which had some further benefit in the early 2000s. And around 2011, 2012, the IMPROVE-IT trial, which in contrast to the PROVE-IT trial was the addition of ezetimibe to standard therapy, showed that there was a further reduction. This is a relative reduction, and the absolute reduction was actually pretty small, and it did take 7 years to get to a result because of the numbers of events in the groups that were reasonably well treated with the statins made the event rate relatively low. So based on a lot of this, I thought now we can look at the 2016 cholesterol guidelines. And this is where we're using, and this is the basis for a lot of our treatment, at least in terms of what the family physicians were doing out there, even though some of us in cardiology may have been a bit more aggressive about the whole treatment. So this is what the guidelines were that were published back in 2016. And who to screen was over the age of 40, perhaps earlier in certain ethnic groups, and who had conditions that may have made them at a much higher risk, ignoring age, such as clinical evidence of atherosclerosis, AAAs, diabetics, hypertensive, smokers, family history of premature coronary disease, chronic kidney disease, significant obesity, etc. And standard lipid profile was suggested based on these guidelines. And in general, it was felt that fasting lipids were better, but if this was not possible, that a non-fasting lipid test was okay. All of these people as well should have their sugars assessed for diabetes, especially in general for risk, and what their EGFR was in order to help assist management. Apoprotein B was optional, especially as it's not really considered quite, shall we say, necessary, so it's not funded in general at most labs. And the ACR ratio, if they're hypertensive or diabetic, which certainly helps in terms of explaining risk. The ACR was as well used in one of the trials to help decide whether people were at sufficient risk to warrant adding in a statin. So this is a cartoon of what we are looking at when we have a non-HDL measure, which is given to us on the lab values based on what the triglyceride levels are, basically. So if the triglycerides are too high, then the labs don't really usually calculate the LDL. You'd have to ask for a measured LDL in these people. And it consists of a wide variant of different sized particles. And the LDL is only one component of this. And who do we consider treating based on risk of prior disease, such as in the top, clinical atherosclerosis, which is what we're basically treating. Also, any abdominal aorta of greater than 3 centimeters, diabetics who are over 40 or who have 15 years of diabetes, and CKD patients. There are trials on that as well. And people who probably have FH with an LDL of greater than 5. So this is a complex slide, and we're not really treating the primary prevention patients. We're looking at the statin indicated conditions of clinical atherosclerosis, basically. And sometimes we'll see people who are found to have atypical chest pain, but an abdominal aortic aneurysm, or they're diabetic, and they should be considered as well. So if we, and we won't discuss today the FH patients with the LDL of greater than 5, because that's a whole talk on its own. So if we follow down the arrow, obviously we're looking at, based in 2016, on statin indication, and the goal at that point was to get the LDL below 2 or a 50% reduction, or to try to get the non-HDL less than 2.6. And if you got to target, then you just followed them. And if you didn't get to target, you could consider add-on therapy. And ezetimibe was considered the first line, and with bile acid sequestrants as an alternative. And PCSK9 inhibitors were second line, and only as an add-on to everything else if there was a failure to reach goal at that time. So we can look at a cartoon of how things work. So if we look on the left side, we can see the statins work on decreasing at the hepatocellular level HMG-CoA reductase, and so there's going to be a decrease in intracellular cholesterol synthesis. But this comes at a cost. What happens is that you have decreased cholesterol within the hepatocyte, and this actually causes a change in the LDL receptors, causes an upregulation in the production of PCSK9 by having a decreased cholesterol content caused by the statins. So PCSK9 is a protein which causes degradation of the combination LDL and LDL receptors, and so the LDL receptors which try to take the cholesterol and break it down inside the hepatocyte are decreased, and therefore you have a release in the and some upregulation in the circulating cholesterol despite being on the statin. And so this led to the development of the PCSK9 inhibitors. So one of the first ones was using evolocumab in the Fourier trial, and with this drug they chose all kinds of different famous scientists, Fourier and Laplace, and named the trials after them inventively, and looked at risk reduction. So this is when it was done in people with chronic disease who had LDL elevation, and actually as long as it was above 1.8 they were looking at it, and they actually enrolled 27,000 people into this. And it was a trial of evolocumab versus placebo in people who had definite disease, additional risk factors, and an LDL of greater than 1.8 or a non-HDL of over 2.6. So this was using different endpoints, aiming for much lower cholesterol, and looking at the primary endpoint, which we'll focus on, composite of CV, death, MI, stroke, hospitalization for angina, or the need for revascularization. So the drug worked really well to get to this level, getting the cholesterol down from a median of 2.38 to a median of 0.78, and it had a persistent benefit in terms of this reduction. And we can see that the looking at the primary endpoint, similar to other trials, after a year things start to separate, and that by a 3-year period there's a 15% relative risk reduction in events. So this is a relatively short trial if we consider some of the earlier trials, which were 5 to 6 years. And the curves we can see visually seem to be continuing to separate over time. Key secondary endpoint, CV, death, MI, or stroke, again had a 20% reduction in the relative risk. And again, it was just under a year for this curves to start to separate. So there appears to be a definite benefit of getting the cholesterol lower. Now, we had mentioned the J curve and the concerns about an increase in risk when you got much lower. And we can see from this that even getting an LDL down to 0.6 had no effect in terms of adverse outcomes, and there seems to be a persistent straight line in terms of achieved LDL as it goes down from 3 to 0.6, with no increase in risk as you go very low. So we can say, why is this? And we have to, if we look at physiologically, when we're born, our LDLs are probably around 0.3 or 0.4. And then through our lifestyle and diets, they come up a lot. And if we have abnormal proteins, they can go up very high. And so we're born with a very low cholesterol when we have our greatest needs for cholesterol in terms of cell production and neuron production. And we have no significant worsening despite having developed higher cholesterols for other reasons over the years. So we can say that based on this, that it works really well. And so this is in a chronic disease population. And so this is just, again, saying about how it worked and how it was maintained over the 3-year period. So then one of the other agents looked at a different population, and this is the Odyssey. So we're not looking at Middle Ages or early 18th century mathematicians, but more Homeric look at the use of PCSK9 inhibitors, and the Odyssey Outcomes trial was done looking at people who came in with acute coronary syndrome, whether it's an MI or just unstable angina, 1 to 12 months prior to randomization, who despite good treatment for at least 2 weeks with high dose statin as much as tolerated, were still had high cholesterol and were then entered into the trial. And so they put in anybody who had an LDL greater than 1.8, and they didn't, they weren't quite as aggressive in getting them very low. And so they adjusted the dose of the drug to get them in a target range of an LDL of 0.6 to 1.3. So it's slightly different. But they didn't have the benefit when this trial was designed of the results of Fourier, which showed that it was safe going all the way down. So we have to remember that when we interpret the results. So there were a large number of patients in this as well, and there were 9,500 patients who were treated with alirocumab, and they had, again, a significant benefit as well. So the primary endpoint was reduced by 15%, this being over a 4-year period, and the absolute numbers were fairly consistent in finding with what was found with the Fourier trial. And again, it was only after 1 year that the curves really started to separate. And this is looking at what the baseline, the forest plot. We can see everything is in favor of treatment, whether it's a non-ST elevation MI, a STEMI, or unstable angina. And the largest population group we can see by the size of the little box, it was in the non-ST elevation myocardial infarctions. And there's no difference, as we can see, with the P for interaction being 0.33. And there's no difference when you look at the time to randomization, that whether it's less than 2 months or later. And if you were able to tolerate a high-dose statin, there was a trend that if you weren't able to be on a statin, that you did better on one, and that you had more of a benefit if you were on alirocumab and couldn't take a statin. But again, the interactions were all non-significant in terms of p-value. But it does say that the value appears to be substantial even if you start very early, less than 2 months. So this is just another view of the major adverse cardiac events, and depending on what your cholesterol was, and because these are subgroups, it wasn't designed to look at this, But overall, we can see the benefit in the left hand, and it looks like in the right hand cartoon that there may be more of a benefit when your LDL is above 2.6 to start with, but because it's a subgroup analysis, it makes it a little bit more difficult to say for sure, because it wasn't designed to look at that. The secondary endpoints that were designed to look at, again, all showed similar benefits. So that led us into what was just published last week, which was the 2021 guidelines for the management of dyslipidemia in the adult. So it's a little bit more simplified in terms of the approach, and our patients would be in the more orangey colored group in the right-hand side, being high-risk patients because they've already had an event. But this is still primary prevention that we're looking at, so I'm not going to talk about this too much. And this is the way that it's approached, however, in general for the family doctors. So if we look at what our patients would be who are already being treated, so we have the two different sides to consider. So this is the last week's recommendation on cholesterol management, so we can't get much fresher than this. So if the LDL is greater than 1.8, then we have to consider increasing therapy. If the LDL is between 1.8 and 2.2, the recommendation is that we add ezetimibe and consider a PCSK9 inhibitor depending on how aggressive we want to be. If the LDL is greater than 2.2, then we should go directly to a PCSK9 inhibitor and consider ezetimibe. I don't know how this is going to work with the some of the pairs, but I think that this has to be considered strongly based on the recommendation and the way that the group deals with the data. This is quite important. At least we do have it, the PCSK9 inhibitors available to us on ODB for many of the patients, and there's a lot of private payers, insurance companies who are willing to cover this. But it certainly does require a little bit more data at this point. Then the question is, what if the triglycerides are high and we have to use the non-HDL cholesterol treatment? So this is if the triglycerides are up, we have to use the non-HDL. And so if the non-HDL is 2.4 to 2.9, we'd go ezetimibe first. If it's already greater than 2.9, consider going directly to the PCSK9 inhibitor first. And if the triglycerides are up in the mid-range, which is 1.5 to 5.6, consider icosapent ethyl, which Dr. Kassam reviewed extensively 2 weeks ago, should be strongly considered. Unfortunately, there's no ODB coverage for this yet. I certainly hope, because of the benefits, which are extremely strong with this agent, that we eventually will get coverage. But as Dr. Kassam's already done a good review, I'm not going to pursue that today. So this is a snapshot of where we are as of now. What's going to happen over the next couple of years? And we should really talk about that. So there's inclisiran, which is a new agent which is in testing, and so it's not available yet. The ESC guidelines are from a year and a half ago, and this is what we really have to think about of what we want to do on our own a bit stronger than what the guidelines currently say for Canada. And if we were willing to follow the ESC more than the Canadian guidelines, depending on our patient population. So I want to mention this briefly. Inclisiran is very interesting. It's not available yet. It actually is, just thinking of some of the vaccines, it's a synthetic RNA, and it works rather than inhibiting PCSK9 when it's made, it actually decreases the production of PCSK9. So it acts in a different way, and it's given as an injection like the PCSK9 drugs, and it's given, as far as I know, twice a year. And this is a cartoon of what happens. So the inclisiran comes as the active protein with a passenger strand that enables it to be taken in to the hepatocyte and into an endosome, and then the passenger strand is cleaved, and it's the passenger strand that works within the nucleus to decrease the synthesis of PCSK9. And we can see that as it goes 1 through 7. And here's another cartoon of which is a little bit more complex, and certainly a lot more complex than Fred Flintstone at the beginning, and showing how the LDL cholesterol, PCSK9 interact, and what happens with the inclisiran working to decrease the production of PCSK9. Thus, there's more LDL receptors, and the LDL receptors clear the LDL from the plasma and cause degradation of the LDL down in the endosomes, and then the protein fragments are modified and digested by the liver and go out in the as non-cholesterol fragments in the bile. So we know that it's an effective drug. This is from one of their Orion trials, and so we've got naming of trials going from ancient history with Odyssey, through the mathematicians with Fourier and Laplace, and now concept of going off into the distant solar systems with Orion. So if we look at percent of people who have a change in LDL over time, this is just the efficacy of placebo, and there's not very many people who, in contrast to regular therapy, have a substantial decrease in LDL in comparison to inclisiran, where very few people have an increase in cholesterol, and there's a substantial decrease in most of them over a 17-month period. And this is just one of the other trials looking at the consistency of response and looking at the PCSK9 levels and how they decrease with this new agent, and how the LDL decreases as well. So what we're all going to be interested in is to see the actual outcome trial, which is in process currently, called the Orion 4 trial. And this is supposed to come out in 2023 or 2024, and this is 15,000 patients worldwide, and it has a good group of chief investigators and chairs, largely in Oxford, and the TIMI group in Boston. So we have that for the future. And then we have to think of where are we now and how do we want to follow. So we have the Canadian guidelines that were reviewed, and these are the ESC guidelines that were released in Paris a year and a half ago now, back in the days when we were able to go to see things. And so they looked and they did a lot of subgroup analysis in many of the trials that had been reviewed in order to try to decide how far should we actually push people down in terms of their cholesterol. So in general, if you look from their 2016 to their 2019 guidelines, in Canada, in comparison, the LDL goal had been 2. Now we're looking more at 1.8. In Europe, they went from 1.8 to 1.4, and at least a 50% reduction in LDL. So aiming for both, not just one or the other. And so these would be, in general, our patients with coronary disease would be in this group. And that the main goal with a class 1 recommendation is that to use a high intensity statin dose because of the efficacy and reduction of an LDL, and less so for using a moderate statin dose because there's less ability to get to goal. And so then if you have a patient who has a recurring event, on their first recurrence, and they feel that they have enough data to have a class 1 recommendation, that instead of aiming for 1.8, we should aim for less than 1.4. And if there's a recurrent event within 2 years, to aim after that, to aim for an LDL of less than 1.0, which is certainly very strong in comparison to what many people can achieve. And they have a fairly simple flow chart to define this, but you just have to remember which goals you're using in your patients. And in general, our patients would be, if you follow across the top, would be a yes, that there's an indication for drug therapy. And then there's several possible goals that we have to look at, remembering that it's important that the patients try to get their cholesterol repeated once they get to that goal, once a year. And some of that is related to how adherent they are to therapy, and whether they've had more events or not, whether the goal needs to be decreased even further. And then in general, adding ezetimibe is a reasonable approach in their view. And if you can get them to go with this, annual follow-up. And if you can't, then in patients who are such as our secondary prevention, that we should be easily ready to go to a PCSK9 inhibitor in order to treat them. In terms of treatment, now this is what's being actually started in the hospital at Centenary. So this is within our hospital system, and because of most of the ACS patients being transferred there for intervention, they're getting lipid profiles on day 1. They're started on therapy, and if they have coverage and if they have a high LDL, despite already having been on agents prior to admission, then they're getting easily considered to have a PCSK9 inhibitor added in hospital. So what is the benefit of this? Anything that you start in hospital, I think we all know from experience, is more likely to be taken persistently after admission. So the non-adherence or the difficulty with management of drugs is much more of a problem in people who are started as an outpatient. And if you actually do start them in the hospital, they're much more likely to be adherent to therapy. So this also gives us a better chance to have the people who do need something like this to be taught about how to use it. And again, the importance of people who come in with an event is having this long-term adherence to therapy. In terms of addition, again, class 1 is high-dose statins. If the LDL is not achieved, we can see here combination with ezetimibe, and if despite 4 to 6 weeks of maximally tolerated statin ezetimibe, addition of a PCSK9. So we're looking at, if we don't start them in hospital, that we should be doing their cholesterols at 4 to 6 weeks, initiating ezetimibe if needed, waiting 4 to 6 weeks, and then if needed, looking at initiation of PCSK9 at that time, and thinking about what our goal is for our individual patients. So I want to thank everybody, and I think we're all able to take questions, and if there's anything else to discuss at this point.
Thank you, Dr. Cherry, for the informative presentation. So we'll move into the question and answer period. For those of you who have any questions, you can use the raise your hand function, or you could type it into the chat box and we'll leave it open. We'll leave it open for a couple of minutes. I just want to remind everyone that over the past couple of weeks, we actually got our new Cardiac Rounds website up and running. Any presentations that we have that we record will be archived on that website. I put it into the chat box. It's www.shn.ca/cardiac rounds, and all archived rounds will be placed up there in the coming weeks after the presentation.
Hey, Jim, it's Salim here. Thanks for the talk. Can I ask you a question?
Sure.
Did I hear there's a differentiation between LDL targets for patients who have atherosclerotic disease without an ACS event and those who have a documented event, one being a target of 2.0, the other being a target of 1.8? Is that what I heard? And can you explain that?
I think that's just the way that it's evolved over time. And so the 1.8 is more of the modern one from this year, and the 2.0 and previously 2.6 were just as the targets came down as the knowledge and information. If we look back to the trials, you know, even the Prove It trial, getting the benefit, they got to an average of 1.8 in the atorvastatin group, but that meant that 50% of the people, because it was an average, were above 1.8. And so a lot of the data had to be assessed further, I think, over time. So I think right now it's reasonable, based on everything, that we aim for 1.8 for all our high-risk patients, which is basically our entire coronary population, whether they've had an event or not.
Okay.
Because that includes the diabetic patients, and using the non-HDL as a criteria, especially when you gave that good talk recently about icosapent. So thank you for bringing that up before this one.
Thanks, Jim.
Salim, what are your opinions about the 1.4 and the 1.0 goals that the ESC has?
So Jim, just to clarify, I gave a talk about cardiovascular risk reduction. Subodh Verma gave the talk around icosapent Just so he was the expert on that area.
Yeah.
No, I mean the data looks like it makes sense. The lower you go with LDL cholesterol, the better you are, and we're just slowly getting there iteration by iteration. But it certainly seems like it's quite logical that the lower you go, there is a reduction in event rates. There's just going to be a sweet spot between an absolute risk reduction and targeting people who are at highest risk to make it worthwhile.
Yeah, I agree. So I think that, and you may agree that this is just one phase of deciding on what our goals should be, and that we'll probably get another iteration of the guidelines in a couple of years, especially as the ESC has been so aggressive in their numbers.
Actually, Jim, that brings up the question. And so the way the science evolves, it's always add-on therapy. So yeah. One of the questions I would have is, in patients who don't meet their goal and end up requiring a PCSK9 inhibitor, where is the data around being able to remove some of the other agents that may not have been as effective? In other words, if the PCSK9 is effective, why can't we consider removing ezetimibe and potentially dropping the statin dose or stopping it completely? And unfortunately, the science doesn't evolve that way. That's the problem.
Yeah. If we went back to the slide on the high-risk patient who has an LDL despite therapy above 2.2, it was in that group that the Canadian guidelines suggested going directly to PCSK9 and skipping the ezetimibe instead of going as ezetimibe first. So it was in the patients between 1.8 and 2.2 in the high-risk group that they suggested adding ezetimibe first, probably because there's a lot of people in that number. And if the LDL, despite the high-dose statin, was still over 2.2, to go directly to PCSK9.
Right.
So that's where we may have I don't know whether we're going to push back from some of the payers if we take that on, but because it's the current recommendations, I think it would be hard for them to refuse. And also anything that we've started in hospital, like is being done over at Centenary currently for a lot of the patients being put on a PCSK9 when they're in hospital, it's hard for the insurance companies to not subsequently pay for the agent. So we're just about at 9 o'clock now, and I certainly hope that this will have helped everybody, and I guess we can call it a morning and get on with our day.
Sounds good, Dr. Cherry. Thank you, everyone. Thank you again, Dr. Cherry, for the presentation this morning, and we'll see everyone back next week. Have a good morning.
Okay, bye.